Hi guys, my name is Christian. Today I'm going to talk a little bit about the sport of basketball and just kind of some of the reasons why I chose the sport and why I'm associated with the sport and kind of just my history with it, my familiarity, and just my own experiences of playing, coaching, still playing to this day, and just having an overall love for that sport. So I'm going to talk a little bit about that. I'm going to talk a little bit about possible injury factors that come along with this sport, as well as the three most common injuries associated with the sport and how to identify those injuries, assess those injuries, and provide a treatment or recovery program with preventative exercise and rehabilitative exercises for those injuries as well. So let's go ahead and talk a little bit first about why I chose the sport. So basically, my self-experience familiarity with it is the biggest reason. Kind of always growing up playing it since I was 5. Organized basketball since I was 13, which completely opened my eyes to the whole real side of basketball and how it's meant to be and with coaches and all that stuff. So that was an awesome experience. Love it. That's kind of what I wanted to do as when I was a kid, was grow up and be a basketball player. So definitely had a big influence in my life. A lot of it had to do with the Lakers. Big Laker fans, you can see here with Kobe and MJ. I love the eras of basketball and how people have grown from the previous generation to the next, and now you can see just how basketball is everyone's just throwing shooting 3-pointers from half court. It's crazy. So definitely the game's changed a lot, in my opinion, not for the better, but still fun to watch. I love coaching. I coached in the past over with an 8th grade team, kind of assistant coached there over in Santa Barbara for a little while, so that was fun. But overall, just always being around it, still playing it to this day is kind of the main reason why I chose basketball. And some of the possible injury factors that come along with this sport, I think one of the biggest reasons is inadequate athletic care and recovery. By that I mean so much stress and emphasis is placed on strengthening when it comes to any type of sport, and especially as a student athlete or a young athlete, a lot of stress is you don't need to recover because you're young, but I feel like recovery is at least 50%, if not more, of if your athletic training program, your performance, all that stuff is going to be involved in your recovery. That's when you're growing. That's when so much more stuff is happening, is actually during your recovery. And getting that proper muscle maintenance, muscle work done, getting chiropractic adjustments, having your nervous system firing all the right way, which is just going to allow your physiological body, everything else, to increase in your performance as well. So many things that are completely overlooked in how to take care of yourself, eating the right things, right, or at the right times when you're training. All those little things are going to play factors in how your body performs. So I think that's a big reason. I see people that are super old, 80-year-olds that are lifting more than 40. The guys half their age, right? And then you see 50, 60-year-olds that are just beaten up, walking around with a cane and stuff. So you can tell who took care of their bodies better. Obviously, there's all different exceptions, injury, trauma, all this different stuff. But for the most part, for the main part, that's a big deal, a big factor that I always like to stress. Age is going to affect a lot of things. Musculoskeletal tissue is going to start wearing down. Osteoporosis could be an effect. All these different, muscle atrophy and trying to get back into it can cause injuries. In your environment, whether you're playing on a hardwood floor inside the gym or you're playing outdoors on a blacktop, those are all going to be different, environments, different, there's gravel outside. You could slip on that. If there's a wet spot, you're going to slip on that. All these different factors can cause injuries. The gender is a big one as well. Gender for any sport, just being because the pelvis bone is the only bone on the body that's gender specific, which is pretty interesting because, the pelvis bone, obviously for women, they're going to be a more wider angle because of, their childbearing. And during that childbearing, that's going to, because their hips are wider, that's going to cause a higher Q angle, which is causing more valgus, stress forces and axial load on the knees, which is just going to cause, allow for a more possible injury, potential risk for injury. So, one of the main injuries, the first one I'm going to talk about, is ankle inversion sprains. And these are the most common ankle injuries. They're going to affect, the lateral ligaments of the foot. And those lateral ligaments are going to be the anterior talofibular ligament, calcaneofibular ligament, and the posterior talofibular ligaments. And depending on the grade and severity, those are the three main ones that are going to be affected. And so the mechanism of injury, the most common one I'm just going to touch on right here, is just kind of decelerating from a jump and landing awkwardly on the floor, either on someone's foot or on the floor in a forced dorsiflex inverted motion, or even just kind of, dribbling, running up the court and kind of just stopping on a dime, and not even necessarily stepping on someone's foot, but just stopping. And that momentum of having your foot plantar flex and invert is just going to keep going, and basically going to end up giving way. And that's kind of what happens is, as the skeletal tissues and the ligaments start stretching and overstretching and eventually tearing, the ankle is going to start giving way. So that's basically what's happening anatomically. Some of the tests and the assessments for an ankle inversion sprains, the anterior drawer test and the talar tilt test are very, huge ones for this type of injuries. And the anterior drawer test is going to determine more the anterior talofibular ligament, whereas the talar tilt test is going to determine more of the deltoid, calcaneofibular, and the posterior talofibular ligament. So those are good. These are great as special orthopedic tests. Just being out there on the field, on the court, whatever it is, wherever you are, you can just do these tests and help kind of determine the extent or the severity of the injuries for your athlete. And, some of the treatments, I'm not going to go into all of them, but just kind of the different grades. It all depends on different grades and severity of the ankle injury, different, rise treatments, different exercises to implement into their treatment program as their body allows them to, as they're growing and recovering, and depending on where they're at, we'll throw a different exercise for them. The main thing here I just noticed is like short-term immobilization worked better than long-term immobilization of the ankle when it came to these injuries. So even though we compress it and keep it, secure, we definitely still want to keep it mobilized. And increasing that proprioception for the ligaments is going to be, it's exactly what we want. So that's always good to keep it moving, and just getting that early manual therapy, soft tissue mobilization, soft tissue massage, getting that specific orthopedic type of work in those areas is going to help a lot. And obviously the exercises, I'm not going to go through all of them. Kind of break them down in another video, but just the main ones I'll talk about is that peroneal strengthening is huge. I think because you're strengthening your lateral compartment of your foot, of your leg, and that's going to just help with strengthening the inversion and strengthening those ligaments in that area. And for rehab exercise, anything with like balancing, on a wobble board, as you progress with like, single leg stands, you add, perturbations, which you could, throw a ball and try to catch it in different areas, in different directions. You can, swing with the kettlebell and add different, movements and different stimulus to kind of activate those ankle muscles and kind of strengthen them. And so these are kind of just some pictures of, typical MOIs of ankle inversion sprains. And you can see the one on the left, he's just kind of stopping real quick, and the other one's coming down, on someone's foot, which obviously they all don't look good. So now we're going to talk a little bit about the ACL tears, or anterior cruciate ligament tears. And mainly what I want to talk about here is just kind of what the ACL does, and it prevents the femur from moving posteriorly during weight bearing, limits anterior translation of the tibia in non-weight bearing, and stabilizes the tibia against excessive internal rotation, and serves as a secondary restraint for valgus or varus stress. So this is very important what the ACL does. It does so much, in terms of and all the different areas that it articulates with, and how it's affecting every movement, like it's saying even valgus or varus stress is for. So it balances both. It takes both loads, which is pretty crazy. And typically the MOI for this injury is going to happen, when someone's decelerating from a jump, forward running with quick planting of the foot, and then the knee gets abducted and changes direction. So when the foot gets planted at the ankle, and then the knee is subject to kind of different loads because of the body or because of forces coming to impact it, that's when usually injury can happen. And a lot of times actually the injury happens even without non-contact, which is pretty scary. I feel like the non-contact injuries can be the most scarier ones at times. So that's basically some of the anatomy of the injury. So some of the tests, the ACL actually had a lot of different tests. So two of them right here are going to be the Lockman's test and the Drawers test at 90 degrees flexion. So I kind of showed a little bit. I'm kind of probably blocking it now with my big old head, but just some of the things determining, for ruptures of ACLs, seeing if the knee and the tibia or the femur is going to be subluxating as we're doing these tests is kind of the main way of figuring out just how much damage and severity of the damage of the ACL happened or occurred in that injury. And some other tests right here. We have the pivot shift test, the jerk test, and the flexion rotation drawer test. So the jerk test is going to be kind of the opposite of the pivot shift test. So excuse me, I feel like I'm gonna sneeze. Oh, sorry. Okay, so yeah, the jerk test is going to be the opposite of the pivot shift test. And that's going to just, again, check for ruptured ACL, testing the anterolateral rotary instability, so how it rotates around the ankle, around the knee. Because as we know, the knee is a modified hinge joint, right? It just flexes and extends, but it does internal rotation as well through the popliteus and how it unlocks the knee. So you're gonna just kind of get that little bit of a rotation in there as well. So, and kind of just checking to see the severity of the ankle. Of the knee. So that's those. And then some of the treatments for recovery. I'm not really gonna talk about all of it, but just, there's non-surgery ways and surgical ways, and kind of the different phases that you would do after each one. Some of the rehab exercises that I have here is a big one's hamstring and quad strengthening, especially hamstring strengthening. I feel like, hamstrings are very underused and very weak, and hamstrings play a big role with ACLs. I feel like if you strengthen the hamstring, because mostly people just strengthen their quads, and that's going to kind of affect, it's going to cause imbalances, postural imbalances in those areas around the knee. And then hop training, and again, balance exercise, single leg stance, balance exercise are going to be the biggest things here for rehabbing the ACL. I'll kind of explain a little bit of those as in another video link as well. And here's just some more pictures of common MOIs in terms of ACL injuries. You can see this is females basketball right here, and you can see how much valgus stress is put on that knee right there, and it just does not look good for her. So let's skip that one. Now I want to talk a little bit about Achilles tendons and just ruptures of the Achilles tendon. And basically, the biggest thing is, Achilles tendon is the largest, strongest, and most important crucial tendons for weight bearing. And it forms from the gastroc and the soleus tendons, and kind of goes into the plantar fascia and opens up there. So the biggest thing, again, like I talked about earlier, is that proper care and athletic care, and just getting that muscle work and all that stuff done, because this is really happens after just years of chronic inflammation to the area and just micro tears over and over, never getting that proper work done. So that's probably the biggest reason why people hurt themselves here. And the MOI mainly is just a forced ankle dorsiflexion. So basically what's happening is there's an eccentric contraction of the Achilles tendon as you're about to push off. And so as you're pushing off, that hyper dorsiflexion is just causing that ripping tear right there, like right in the Achilles area, because your calf wants to go one way, and you're overstretching at the same time. You're kind of pushing it away and kind of just shearing it. So that's kind of what's going on with the injury and mechanism of injury. And just one of the tests that I found was the Thompson test is a famous one for the ruptured Achilles, and just kind of, squeezing the calf and kind of, just basically having them do active plantar flexion, and just seeing basically obviously if they have pain, they're going to have, or no movement is a positive sign for ruptured Achilles. So they're not able to plantar flex their foot. That's going to basically be a positive sign for that. And some of the treatments obviously is surgery. Definitely going to be, out of commission for a little while. You're going to be on non-weight bearing cast for 6 weeks, and even a walking cast for 2 weeks after that. And just kind of the different exercises that kind of go, in progressive resistance exercises that are kind of helping them, gain that strength back. And some of the exercises here, I'm just going to talk quickly about just, I think functional strengthening, like with hip abduction, I think is huge. Again, functional strengthening is so important because that's, our arches of our feet actually come from our hips, right? So as we strengthen our hips with hip abduction and strengthen our lateral rotators, we're going to take pressure off our Achilles. And I think it's so important because, we need to look at the bigger picture and the more global picture in terms of injury, and not just focus on, the area that's hurt and the injury, the site of injury. So, towel gathering, dropping is a great one. Just, with activating your plantar fascia and picking, the towel up and dropping it, picking up marbles is a good progression to that. And, just always adding load and resistance to, whatever you're doing is going to help, with those, injuries and helping them recover quicker and faster and stronger. So here I just kind of want to end with, again, how that happens as the foot is dorsiflexed, right? And then you try to plant and push off with the balls of your feet. That's going to cause that tear in that calf muscle into the Achilles tendon, which is huge. And it happens so quick it happened to Kobe. It's one of the biggest major injuries that happened in basketball because it's definitely career threatening, and it definitely took a lot of our the best basketball players that's have ever lived have even had a lot of trouble recovering from this one. So well, thank you so much. I hope you enjoyed everything, and I'll send a YouTube link in terms of all the exercise videos.